Our research began with the obesity epidemic, but devolved into a much deeper and broader investigation. The prevalence of obesity has been significantly increasing since the 1980s. Data from the 2013 to 2014 NHANES, the National Health and Nutrition Examination Survey, confirms that 70.2% of American adult men and women are considered overweight or obese, and as many as 37.7% are obese. Obesity has become both a medical and public health concern because of the many comorbidities that are associated with it, such as cardiovascular disease, hypertension, type 2 diabetes, non-alcoholic fatty liver disease, and a variety of cancers. Pediatric obesity in the U.S. has become a national crisis, with 31.7% of children either overweight or obese as early as 2008, according to the NIH. Weight loss diets have been the main therapeutic modality for weight management problems as far back as Hippocrates, and still today, it is the single most utilized weight management strategy. Yet studies have found that caloric-restrictive diets, despite causing rapid and significant weight loss over the short term, are not efficacious in sustaining weight loss over the long term. So what is going on? Why have the medical and nutritional communities been unsuccessful at containing the obesity epidemic? A comprehensive review by Mann and colleagues, published in American Psychologist in April 2007, concludes that one of the most important conditions for weight gain in later years and persistent form of weight problem is previous dieting. This seems almost inconsistent with basic logic. The research basically concludes that dieting causes weight gain. This does not make too much sense. Or does it? In the review, Mann and colleagues found that weight loss programs consistently report a loss of 5 to 10% of body weight over the short term, but significant weight regain in the follow-up period. Overall, they report that 33 to 67% of subjects regained more weight than lost. In one study that had a 2-year or more follow-up period, 83% of patients experienced a weight regain that was greater than the weight lost. More disconcerting was the notion that even in 4 to 5 year follow-up periods, there was no sense that the rate of weight regain leveled off. Non-randomized prospective studies have also found that diets were ineffective in managing long-term weight loss. In fact, 7 prospective studies concluded that dieting was strongly associated with future weight gain. Diet and exercise were also proposed as strategies, but were not found to be successful over the long term. The Look Ahead study was the most comprehensive diet, exercise, and lifestyle study. It lasted 8 years and found that 50% of the overweight and obese subjects lost 5% or more of their initial body weight using behavior modification. But they did not find that the morbidities and mortalities were any different from controls. The conclusion that we can draw from this is that diet restrictions and exercise are not effective therapeutic modalities in the long-term treatment of obesity. Richard Carmona, the Surgeon General of the United States, at a Commonwealth breakfast in San Francisco in 2008, addressed this particular paradox. Our team proposes that obesity should be considered more as one symptom of a much larger social malaise that is affecting American society. We advance that the breakdown in family integrity and the rise in single-parent households are the main vectors driving not only obesity, but also epidemics like depression and anxiety, the rise in adverse childhood experiences, risky sexual behavior, sexually transmitted infections, substance abuse, sedentarism, suicide, and suicide ideation. In that sense, obesity is then considered as one epidemic among a variety of other epidemics. The literature does in fact support the idea that single-parent households and divorce, in addition to family dysfunction, are the driving forces behind many of the epidemics, obesity included. In fact, Geisis and colleagues found several review articles that supported the notion that parental separation was negatively affecting children's cognitive skills educational outcomes, and emotional and psychological well-being. These negative impacts can be encapsulated within adverse childhood experiences. Let us first take a look at family dysfunction. The literature divides the functionality of families into two paradigms, one being an unhealthy functioning family, and the second, a healthy functioning family. I want to examine the traits attributed to a healthy functioning family. Guidelines describing what makes up a healthy functioning family are proposed by the American Academy of Pediatrics. The first trait is that there are traditions, rituals, and routines in the family. The second, there is an active participation in extended family and community. Third, there is a taking of moral and social responsibility. Fourth, there are realistic family and personal expectations. And fifth, there is an individualized relationship with each child. Of all the traits that make up a healthy, functioning family, the literature appears to place high priority on structure, routines, and rituals, as they provide stability and predictability for everyday life. This is why Spinoza and Fiese write, "Both routines and rituals serve important roles in maintaining structure and the emotional climate of daily family life." One of these rituals that has gained some traction in the literature in recent times are family meals and nutrition. This is because they are rich in symbolism and meaning. Dietitian Kathleen Zellman emphasizes that point. She writes, "Meal times can provide quality time for the whole household, fostering family unity and trust, providing a setting for moral and intellectual discussions that reflect family values." However, there has been a considerable decline in the frequency of family meals. Indeed, currently 42% of children report eating less than 5 meals per week with their parents, a value that has been creeping upward since the late 1970s. The process of meal disruption began subtly enough with the frequency of meals eaten away from home, gradually rising in prevalence. It seems that by the 1960s, schedules became busier, and the opportunity for family meals began to decline. As families ran off to restaurants and fast food outlets, the homemade meal was redefined with fast food-like meals and processed foods, a clear cheapening of food quality, symbolic also of the poor nurturing. These meal disruptions were further accentuated by the rising prevalence of single-parent families. The Annie E. Casey Foundation estimates that 35% of American children live in single-parent families. So then the question of interest is, how do single-parent families lead to meal disruption and poorer quality nutrition? The literature confirms that after separation and divorce, economic resources significantly decline. Poverty or near poverty afflict many single-parent households. This translates into less money for fresh fruits and vegetables, and less time dedicated to establishing those vital routines and rituals. Enter fast food and processed ready-to-eat meals, often consumed alone or in isolation. Confirmed in the literature is the association between single-parent households and divorce, and the prevalence of poverty, obesity, and overweight in children. What also can be gleaned here is that meal disruption within the context of separation and divorce is strongly associated with both poorer mental and physical health of youth. Indeed, the literature was so abundant about the impact of meal disruption that we had to revise the epidemiological algorithm we had originally developed. In this newer version, mealtime disruption is elevated one notch so it can extend its reach to a variety of key epidemics. Research that was done by the National Center on Addiction and Substance Abuse in the 1990s showed a definite association between frequent family meals and reduced risks of substance abuse in children and adolescents. Others have shown a protection against risky sexual behavior, disordered eating, delinquent behavior, obesity, and other adverse childhood experiences. It was, however, the work of Eisenberg and Olson, in addition to that of Harrison and colleagues, that singled out frequent family meals as protective against suicidal ideation and depression among adolescents. So the graph is showing how meal disruption has a much broader and deeper reach than originally thought. This should come as no surprise, since feeding nutritional meals to the family is richly endowed with the idea of nurturing and loving. Frequent family meals also translates into a 12% decrease in the odds of being overweight, a 20% decline in the odds of eating unhealthy foods, a 35% drop in the risk of disordered eating, and a 24% jump in the odds of consuming healthy foods. Many of these irregularities in eating appear to be tied to family dysfunction and breakdown. Specifically, the literature identifies low family cohesion, poor family relationships, and impoverished family social environment as the main vectors creating meal disruption and poor nutrition through chaos and conflict, with a clear impact on both the physical and mental health of the children. So then, what is the solution? There is a lot of research showing the benefits of eating even as little as 3 family meals per week. In this context, children and adolescents have a 24% reduction in the odds of eating unhealthy foods compared to families having less than 3 family meals per week. What can we take away from the literature? Well, it seems that Geisis and colleagues understand well the consequences of parental separation on children. They write, "Changes in family structure are intrinsically harmful for children because of the changes in roles, routine, parenting quality, and parental contact." Our research appears to indicate that most of these changes are in fact intertwined with the lack of family meals. So it seems that it is the family meal that we cannot do without. So this presentation's conclusions are that the social and medical upheavals now experienced by American society can be better managed if more resources and counseling can be directed at assisting dysfunctional families and encouraging the generation of healthy functioning ones. There are several benefits to this strategy. First, it decreases the risk of families devolving into separation and divorce, and ultimately single-parent households. Second, a better management of dysfunctional families leads to improved parent-child relationships. There's a decline in overall adverse childhood experiences and in weight management problems. Depression is less prominent among children and adolescents. And finally, meal disruptions, which carries a multitude of consequences, are minimized.